Good afternoon. The subcommittee will come to order. This afternoon, the subcommittee holds an open hearing on the fiscal year 2015 budget request for the Defense Health Program. I'd like to welcome Dr. Jonathan Woodson, Assistant Secretary of Defense for Health Affairs, Surgeon General of the Army, Lieutenant General Patricia Horoho. I always mispronounce that. I apologize. The Surgeon General of the Navy, Vice Admiral Matthew Nathan, Admiral, and the Surgeon General of the Air Force, Lieutenant General Thomas Travis. Let me say particularly to Vice Admiral Nathan, thank you for your special work with our friend and colleague, the late Congressman Bill Young. You and your team did some remarkable things, and I just want the record to show that on behalf of all of us, we're very grateful. And all of you were interested and involved, and let me thank all of you for their high level of interest. I thank all of you for your service and welcome you back to the committee. As always, the committee remains committed to providing the very best in medical care to our servicemen and women, all volunteers, as they put their lives on the line for us each and every day. Whether at home or abroad, they deserve the best physicians, nurses, healthcare professionals, equipment and technology available to treat whatever wounds they sustained, whether they be physical or mental. And that is for the long time, whether they remain in the military or whether they go in and they become, as they immediately are, veterans. For example, more than 1,600 personnel now bear amputations. I've seen estimates that I've read, and I've seen estimates, and I've read estimates that up to 400,000 individuals are suffering from post-traumatic stress disorder or syndrome. And of course, there are many cases of TBI, a traumatic brain injury. Many of you saw the front page Washington Post story on Sunday, A Legacy of Pain and Profile. The piece reports that more than half of the 2.6 million personnel deployed to Iraq and Afghanistan struggle with physical and mental health problems stemming from their service, feel disconnected from civilian life, and believe the government is failing to meet their needs of this generation's veterans. Retired Army Staff Sergeant Christopher Stevens crystallized the mission that this committee and the Department of Defense has before us. He said, and I quote, "I raised my right hand and said I will support and defend the Constitution of the United States of America. I gave them everything I could. I would expect the same in return," end of quotation marks. And he should expect the same in return. We recognize that the Veterans Administration bears responsibility here too. But as far as the active guard and reserve personnel are concerned, your department and this committee commits ourselves to giving our soldiers, sailors, Marines, and airmen everything they need. We are keenly aware that the Department of Defense faces a tremendous challenge with the growing cost and long-term sustainability of the military health care system, a system with about 10 million beneficiaries. Military health care costs have risen from $19 billion in fiscal year 2001 to approximately $47.4 billion in fiscal year 2015 in your budget request. This budget request assumes savings associated with several controversial TRICARE benefit cost-sharing proposals. I would note that these recommendations must be ultimately approved by Congress, and they've been rejected in the past. The committee is interested in hearing more about them today. Additionally, the committee remains distressed about the unacceptably high rate of suicide and sexual assault and the ability of the Department to provide mental health counseling for service members. It is imperative that the Department get to the heart of these two critical issues. We also remain concerned, after years of substantial investment, over the continued lack of an electronic health record that will help our service members seamlessly, we've been using that term for quite a long time, transition their care from the Department of Defense to the Department of Veterans Affairs. This is an issue with real-world, day-to-day implications for our troops and our veterans. The initial mandate for an integrated record was included in the fiscal year 2008 National Defense Authorization Act. Now, 7 years later, we have yet to see working interoperable records between the two departments. This is unacceptable, and the committee needs to know that progress is occurring and that this challenge will soon have a solution. So, welcome back. We welcome your testimony. And at this time, I'd like to turn to my ranking member, Mr. Visklosky, for any comments or statement he'd like to make.
Thank you very much, Mr. Chairman. Mr. Chairman, I thank you for holding this hearing to address questions as to how we care for our service members and their families. I also do want to thank our witnesses for their testimony. Your remarks and frank answers to our question are essential to our deliberations on the fiscal year 2015 budget request. In order to preserve the readiness of our U.S. forces and our ability to provide world-class care, this year's request proposes to control the growth of personnel and health care costs that consume an increasing share of the defense budget. I recognize the need to address these problems, problems that have proven to be some of the most difficult to resolve in light of unsuccessful attempts in the past, with plenty of, if you would, responsibility resting in the Congress as well as the current and past administrations. As we proceed, I believe that all of us want to also ensure, however, that these changes are equitable in their impact. With that, I thank you for your service and your testimony today. Thank you, Mr. Chairman.
Thank you, Mr. Visklosky. Mr. Secretary, the floor is yours. Your entire printed statement will be put on the record, and we're glad you're back. Thank you.
Well, thank you very much, Chairman Frelinghuysen, Ranking Member Visklosky, and members of the subcommittee. Thank you for the opportunity to present the Department of Defense request for fiscal year 2015 health program funding. Our national security and defense strategies must be supported by a strong, relevant, agile, and forward-leaning military health system. Our service members deserve and the American people expect excellent care delivered reliably, effectively, efficiently, and compassionately anywhere our service members are stationed or deployed. Our FY 2015 budget supports these efforts and supports our quadruple aim of increased readiness, better health, better care at lower cost. We are committed to sustaining the medical readiness of our forces, the clinical skills of our medical forces, and the world-class treatment and rehabilitation for those who fight battles today, yesterday, and tomorrow. This budget also sustains our long-term medical research and development portfolio, allowing us to continually improve the care for the warfighter. The military health system has performed well in 13 years of war, achieving historic outcomes in our ability to reduce the rate of disease and non-battle injury in the combat theater and to increase the rate of survival of war wounds. We are proud of these outcomes, but in order to meet our mission in the face of changing threats and limited resources, and working closely with the Surgeons General, I've outlined 6 lines of effort for the military health system in support of the Secretary's priorities. These include modernizing the military health system's management with an enterprise focus, define and resource the medical capabilities and manpower needed in the 21st century, invest in and expand strategic partnerships, assess the balance of our medical force structure, modernize the TRICARE health program, and define the military health system's global health engagement requirements. For this hearing, I would like to focus on 2 of these efforts that directly relate to our budget request for this year. The Defense Health Agency, a designated combat support agency, is an important first step in modernizing our common business and clinical practices with accountability for performances both to the Assistant Secretary of Defense for Health Affairs and the Chairman of the Joint Chiefs of Staff. We have incorporated 7 of the 10 shared services into the Defense Health Agency, and we have made substantial progress in achieving savings earlier than the projected as we consolidated functions and we reduced redundancy and variation. Our proposal for FY15 budget also includes efforts to modernize the TRICARE program. This proposal will simplify and modernize the existing TRICARE program in ways that provide incentives for wellness, decrease overutilization, and allow beneficiaries to choose their providers. This proposal includes modest increases in beneficiary out-of-pocket costs. I fully recognize that any increase in out-of-pocket costs for our beneficiaries introduces concern from those we serve, the organizations that represent them, but I want to make clear that the TRICARE benefit will remain one of the most comprehensive benefits in this country, and it will modernize the program for the first time in many years. Mr. Chairman, we understand that the Department of Defense must do its part in addressing the nation's budget concerns, and that it must be done in a responsible and judicious manner. I believe this proposed budget meets the test, and I am hopeful that working collaboratively with Congress and our military service member and the Veterans Organization, we can reach an agreement on the budget proposals. I thank you for the opportunity to speak here today, and I look forward to your questions.
Thank you, Mr. Secretary. Lieutenant General Horoho, the floor is yours. Thank you for being with us.
Thank you, Mr. Chairman. Chairman Frelinghuysen, Ranking Member Visclosky, and distinguished members of the subcommittee, I thank you for this opportunity to tell the Army medicine story. On behalf of the dedicated soldiers and civilians that make up Army medicine, I appreciate the support that Congress has provided. I want to start by acknowledging America's sons and daughters who are still in harm's way today. We have 32,000 soldiers committed to operations in Afghanistan, an additional 120,000 soldiers forward stationed or deployed in nearly 150 countries, doing the work of freedom. Since 1775, the Army's medical personnel have served with our fighting troops and received them when they returned home. We do this by focusing our efforts across 4 priorities: combat casualty care, the readiness and the health of the force, a ready and deployable medical force, and the health of our families and retirees. Just as the health of the nation and the health of our Army are not separate entities, the health and the readiness of our Army are inseparable because health is a critical enabler to readiness. Today, I am proud to report that we're beginning to see results in readiness, in health, and cost savings. Through our service lines and standardization of processes across the medical command, we have synchronized our policy, programs, and resources, and we're starting to see some very strong results. Our medical and dental readiness is at its highest level since 2001. Our performance triad of healthy sleep, activity, and nutrition is spreading across our Army and Army family. Since embedding behavioral health capabilities in the brigade footprint, soldiers used outpatient behavioral health care more frequently, had fewer acute crises, and required approximately 25,000 fewer inpatient psychiatric bed days in 2013 compared to 2012. This brought a cost avoidance of approximately $28 million. The Army Wellness Centers are seeing early indicators in improved health. For the 2,400 individuals who were followed, 62% saw a 4% decrease in their body mass index and a 15% increase in cardiovascular fitness and oxygen consumption. Our patient-centered medical home led to a 6% reduction in overutilization of emergency room visits, which equates to a $16.3 billion cost avoidance and a decrease in polypharmacy of almost 50%. I believe this is only the beginning as we continue towards a system of health. Army medicine ensures the Army maintains a medically ready force and a ready medical force. Our health care providers require professional and operational development, which begins in our military hospitals. The Army medicine operating force provided 70% of combat casualty care in Iraq and Afghanistan. This valuable experience permeates into our education and our training base at the Uniformed Service University, AMED Center and School, in our Joint Medical Educational Training Center at Fort Sam Houston. Our programs are outlined further in the written testimony. So I want to take a moment to acknowledge what is not in my written testimony, and that is this is a time of hard conversations and very tough choices. For the first time, we are decreasing the size of our Army before the longest war in our nation's history has ended. We are poised to transition to the interwar years, and we must work aggressively to sustain our combat care skills, nurture an environment of dignity and respect, and maintain trust with the American people. As a leader, I get asked what keeps me up at night. I worry about the long-term repercussions of these wars on our veterans. I worry about sexual assault and sexual harassment occurring across our nation and Department of Defense. I worry about losing momentum towards building the health, resiliency, and readiness of our armed force. I worry about the loss of science and technology that has accelerated medical advances that give the American public confidence to allow their sons and daughters to serve. Our nation has the best military medical team in the world, and there is no true equivalent within the civilian sector. We're a combat multiplier, we're drivers of medical innovation. What our men and women in the military medicine do every day on deployments and in garrison is what makes military medicine unique, and it's what makes me very, very proud. This is both a time of challenge and a time of opportunity. The nature of war will always have medical threats. Our job is to be ready whenever and wherever. Anything less will cost lives, and this is not going to happen on my watch. Though we live in uncertain times, one thing is certain. A healthy, resilient, and ready Army will be, as it's always has been, the strength of our nation. I want to thank my partners in the Department of Defense and the VA, my colleagues here today on the panel, Congress, for your continued support. The Army Medicine team is serving proudly. Honored to serve. Thank you.
Thank you, General. Admiral Nathan, welcome.
Thank you, sir. Chairman Frelinghuysen, Ranking Member Wisławski, distinguished members of the subcommittee, I am grateful for the opportunity to appear before you today on behalf of the dedicated men and women of Navy medicine. We want to thank the committee for your outstanding support and your confidence. I can report to you that Navy medicine and our team is mission ready in delivering world-class care anywhere, anytime. Navy medicine op-tempo remains high, protecting, promoting, and restoring the health of sailors and Marines deployed around the world, ashore and afloat in all warfare domains, above the sea, under the sea, and on the land. We wish to support the operational missions of both. We exist to support the operational missions of both the Navy and the Marine Corps. These responsibilities require us to be an agile, expeditionary, medical force capable of meeting the demands of crisis response and global maritime security. Within Navy medicine, our planning efforts must always be synchronized with the Navy and Marine Corps. Our way forward reflects purpose and commitment to build on the work and investments we made last year. Our strategic goals remain as they did: readiness first, value, and jointness. The goals are critical to sustaining our readiness mission, remaining flexible in the face of changing operational requirements and fiscal challenges, as well as effectively managing our resources. They also leverage the use of technology and telehealth, help standardize clinical and business processes, and improve alignment. Throughout Navy medicine, our leaders are achieving measurable progress in these goals, and I am encouraged that these priorities are taking hold throughout our enterprise. By leveraging the capabilities of our patient-centered medical home port, and initiating our CONUS hospital optimization plan, we are moving more workload into our MTFs, we are growing our enrollment, we are rebalancing staff, and reducing overall purchase care expenditures. Just as importantly, we are ensuring that our graduate medical education programs remain second to none, and our provider teams sustain the clinical currency to always be battlefield ready. The establishment of the Defense Health Agency is an important milestone for the military health system, and our collective efforts to realize potential efficiencies and savings. Navy medicine is working with the DHA in conjunction with our partners in the Army and the Air Force to ensure that rigorous business case analysis is conducted and validated for the shared services, while we continue to focus on improved integration of healthcare, benefits, and services in the 6 enhanced multi-service markets. Strategically, I am convinced that we are stronger as a result of our work with the other services, our interagency partners, our leading academic and private research institutions, as well as other civilian experts. These collaborations are essential. They are important as we leverage efficiencies and best practices in clinical care, research, education, global health engagement, and supporting our wounded service members in their recovery and ultimately in their transition. Psychological health is an important component of overall force health protection. We recognize that prolonged operational stress can have significant and potentially debilitating consequences. We continue to embed mental health capabilities in operational units and primary care settings in order to identify and manage issues before they manifest as psychological problems. This priority extends to suicide prevention efforts, where we train sailors, Marines, and their families to recognize operational stress and use tools to manage and reduce its effects. As leaders, we have renewed our emphasis on ensuring that we focus on every sailor every day, particularly those in transition who may be facing personal or professional adversity. We know that an increasing sense of community and purpose is an important protective factor in preventing suicide, and we must remain ready and accessible to those who need our help. These are transformational times in military medicine. There is much work ahead as we navigate the important challenges and seize the opportunities to keep our sailors and Marines healthy and maximize the value for all our patients and leverage our joint opportunities. I am encouraged with the progress we have made. I am not yet satisfied. We continue to look for ways to improve and remain on the forefront of delivering world-class health care anywhere, anytime. Again, thank you, sir, and I look forward to your questions.
Thank you, Admiral Nathan. General Dr. Travis, thank you for being with us again.
Yes, sir. Thank you, Mr. Chairman, Ranking Member Visclosky, distinguished members of the subcommittee. Thanks for inviting me to appear before today. Our military forces in this nation have benefited from the vast achievements Army, Navy, and Air Force medics have jointly made in deployed and en route care since the beginning of the current war. With this war winding down, and it's not done, even with our fiscal challenges, we now have a clear responsibility to make sure military medics are well-trained and well-prepared for whatever contingency the future brings, to include combat operations, stability operations, humanitarian assistance, or disaster relief. To enhance our core competency in the ground expeditionary mission, or in our case the AeroVac mission, we must ensure that our providers continue to have robust opportunities to practice their skills, and that we continue to pursue critical research and modernization initiatives for the future. We have very successfully leveraged civilian partnerships to maintain trauma skills readiness, and as this war subsides, I'm convinced we'll rely even more strongly on these relationships to help us train and conduct research. As the way we fight wars evolves, the way we provide medical support for operators must also evolve. Airmen who are manning systems such as distributed common ground stations, space and cyber operations, or remotely piloted aircraft, and those who operate outside the wire, such as security forces, special ops, and explosive ordnance disposal specialists, just as an example, all face distinct challenges. These types of injuries or stressors, both visible and invisible, to members and their families are also changing. We must provide medical support in different ways than we have in the past to address what we describe as an expanding definition of operator, and step up to our role as human performance practitioners. Not only will access and care be more customized for the mission, but so will prevention. For example, we've embedded mental health providers with the right level of security clearance in several remote warfare units to be readily available at the duty location to provide early intervention and care for those experiencing occupational stress that could affect their performance. These important operators may not otherwise have sought care. The Air Force is committed to the Department's plan for reorganization of the military health system to include the establishment of the Defense Health Agency. There are many changes in the works for how we will operate, and you've heard some from my partners. We're excited to be fully engaged with our partners in this very tough work. And it is tough work as we continually focus on providing trusted care and maintaining a fit, healthy, and ready fighting force. Personally, I've been in the Air Force for 37 years, first as a fighter pilot and now for many years as a physician. In my career, I've never seen a time when it's more evident how important military medicine is to the operational capability of this nation. We've learned much, and our medics have performed magnificently. Even in the face of budget challenges, we have to be as ready at the beginning of the next war as we are now at the end of the current war. I think our nation expects that. Your continued support of Air Force medicine, military medicine, and our mission is greatly appreciated. Thank you for that support and for having me here today.
Okay, thank you on all of our behalf. Before I yield to Ms. Granger, we pay tribute to the joint work that you've done in Afghanistan. We still have 33,000 plus, actually, soldiers and Marines and seamen and you name it, Air Force personnel over there. And if the public only knew what happens on the battlefield and the fact that those medics are right there, that immediate transport within the golden hour, that incredible trauma hospital that does things, the genius and courage of the people who do that airlift, and then to land stool where, you know, often parents are there wringing their hands and worrying, and then, or perhaps from home, and then their transport back to the continental United States. It is an incredible achievement, and and the statistics are human, the lives that have been saved. So I know on all of our behalf we feel very strongly about the work you've done, and it's not over. We don't know exactly what our exit strategy is out of Afghanistan, but that, in some ways, it makes it even more dangerous to be there. So it's good to know that you have personnel on the ground that do some remarkable things in the face of huge adversity. Ms. Granger.
Thank you. Thank you all for being here. Dr. Woodson, I have a question. I had the opportunity to talk with Navy SEAL Marcus Luttrell about all the treatments he's received on traumatic brain injury and post-traumatic stress disorder. He told me the only treatment that worked for him he received at the Carrick Brain Centers. And last week he told me, he said that was the first time he had been able to sleep all night since he was injured. I went to visit Carrick and to see the treatment firsthand, and the results were just amazing. Carrick is it's a multidisciplinary brain rehabilitation center, and they combine evidence-based diagnostics with leading-edge technology and treatment to help people suffering from brain injuries due to physical or emotional trauma. And they use a very innovative approach that, they explained to me, retrains the healthy part of the brain to take over the functions of the part of the brain that's been damaged. My question, when we identify successful treatments like that, I think it's important that all of our service members have an opportunity to benefit from them. But unfortunately, these treatments are labeled experimental, so TRICARE won't cover any of the cost. My question is, what needs to be done so that we can have those innovative treatments or treatments outside of the military to be available to all of the military? I think we're missing huge opportunities.
Thanks very much for that question, and I agree with your sentiments wholeheartedly. Let me provide two brief answers to the question. Number one, I do think we need to develop a more flexible approach to bring evolving treatments and strategies more rapidly into the TRICARE plan, if you will. And in fact, we have been discussing this recently because of other issues that have come up relative to new approaches to diagnostics. One of the issues for TRICARE to deal with is that it is a defined benefit that kind of looks like an insurance product, and so we're sort of limited sometimes by the Code of Federal Regulation in terms of this business of proof. Having said that, I think the issue is it's time to work out a system where we can go ahead and provisionally cover these evolving practices and create more flexibility in the program, so I agree with you. The second piece I would just say is that I agree with the treatment strategy that you've outlined, and through the National Intrepid Center of Excellence and additional sites that have been generously funded by the Fisher Foundation, we are incorporating just those same practices and making them available throughout the military for service members with brain injuries.
Good. I think it's just very, very important. I'd say to anybody else that isn't familiar with, I certainly was not familiar with it, but to visit that would be certainly worth your time. Thanks. Thank you. Thank you, Mr. Chairman.
Thank you, Ms. Granger. Mr. Moran.
Thanks very much, Mr. Chairman. Dr. Woodson, as you know, the costs, I have a little cold, so excuse me, cost of military health care has more than doubled over a little more than a decade now, from less than $20 billion to almost $50 billion. Now, fees for TRICARE beneficiaries were set almost 20 years ago, and they haven't changed, even as the cost of health care has increased dramatically over time. Over the last decade, CBO reports that DoD healthcare funding is far outpacing inflation, and costs are going to rise even further in the coming years. So what we see now as something that's beginning to squeeze our defense budget is going to become ever more pronounced in the years ahead as we have more and more uniformed personnel returning from combat and the like. You've proposed changes to TRICARE that are intended to incentivize a more effective and efficient form of using health care. Now, it's my understanding that the Department has substantial data that show that it's actually a fairly small percentage of TRICARE users that are termed super users of the system. They have much higher costs because they tend to use the most expensive forms of health care and do it far more frequently. For example, instead of seeing a nurse when their child has a cold, they go to the emergency room. It's done in civilian life, and it's done with DoD hospitals as well. Now, could you share some of this data with the committee, because it may be possible to gain a better grasp of what's driving this dramatic increase in health care costs?
So thank you very much for the question, and you've outlined a lot of very pertinent issues nicely. So in 1990, early 90s, the Defense Health Program budget was about 4% of the base budget of the Department of Defense. And as you've outlined, since the year 2000, 2001, we've more than doubled from 19,000 to a height of about $54 billion in 2012. We have made some management changes and some program changes to save about $3 billion per year. And our current budget of that we're proposing of $47.5 billion is about 4% below what the height was, basically. So we've made changes, and but the issue is that we've still grown from about 9.5 or so % of base budget to just about 10% of base budget. So we're pedaling harder, but we're not catching up. And the reason is that over the course of TRICARE, of course, the fees have not gone up. Some fees have actually gone down. So the catastrophic cap, which was $7,000 when CHAMP was originally instituted and TRICARE came on board, is now $1,000, and there have been adjustment in other fees, and if you take it in real 2014 dollars, they have actually gone down. So we're doing, I think, what we should be doing in terms of management to make it as efficient as possible, but we do need to readjust the program to provide the incentives for the right utilization of care. Right now, particularly in the retiree, the working age retiree who are in our TRICARE Prime program, they actually consume more resources, health care, than sort of age-matched folks who have a civilian HMO program. So we do have substantial data that we need to revise the system to incentivize the right utilization of care, but provide the access. It's really important that we bring a lot of these in line. The last thing I would say is that as it relates to TRICARE, I think all of the stakeholders have tried to provide a very robust product for the beneficiaries, and they deserve it. But these have added costs. So TRICARE for Life, for example, was introduced and is probably represents about 30 to 33% of the increase in cost over the early decade of the 2000. Is a robust product, but carries with it no cost share and no enrollment fee. And so what we've tried to do is not bring in draconian changes that produce a lot of out-of-pocket costs, but bring in modest costs that, in fact, will help produce a more enduring and efficient program. So
well, I appreciate that, Dr. Woods. But in Medicare, for example, we find that about less than 20% of the beneficiary population incurs more than 80% of the costs, and I was just wondering if that doesn't apply to TRICARE as well. But I have a follow-up question on this. I wonder if you've considered alternatives that increase the cost sharing for working age military retirees, because when I look at what you're doing, it's not going to relieve the pressure on the rest of the budget. It's going to affect force personnel and any number of other priorities. But often, working age military retirees will retire from the military, but very quickly find work in the private sector, which is what we expect them to do. But they hold on to their TRICARE health plans because they're so much cheaper than any civilian health plan. So you have to wonder, wouldn't it make sense to have a tiered approach to cost sharing so as to protect the more vulnerable and younger, less established beneficiaries?
So it's a very good question and proposal, and in years past we have offered up tiered approaches to the cost share, we certainly can look at that. I think what we've offered up this year is a proposal that modernizes the product, but also provides a better cost share. When the program originally went into place, there was about a 27% cost share for working age retirees. That now has fallen to about 9.3%.
So it's dropped from 27% to 9%.
9.3, yeah.
9.
And under our proposal, we readjust the fees so that they have about an 11% cost share. So we have moved in the right direction. And I appreciate the CBO report that you mentioned in your statement, but we have tried tiered approaches before. We think that the proposal this time around gives the beneficiaries something as we're asking them to pay a little bit more, which is a modern approach with fewer encumbrances. So the proposal this year removes this authorization of referrals, which has been a major dissatisfier for folks using the program. So they get something even as we're asking them to pay a little bit more.
I've used up my time. I thank you, Doctor. Thank you, Mr. Chairman.
But he needs an answer, I think a better answer to his question. If there's super users, is it family with multiple issues? I think we need a better handle on that. But you'll provide that information for us, or we'll follow up with some questions. Mr. Kingston.
Thank you, Mr. Chairman. Dr. Woodson, I wanted to continue along these lines that Mr. Moran brought up. I'm wondering, and maybe you've done this, but have you ever looked at the testimony of, say, your predecessors as far back as 10 years ago to see what they did, what they said? Because, and I don't say this critically because we're all a little bit guilty, but it's always this forward thinking, we're going to do it robust, we're going to have the best quality health care, we're going to do this and that. And I mean, your testimonies could have been written by Madison County ad people. And I just say that, again, not trying to be critical, but that's what we would have been hearing 10 years ago, regardless of who the administration is. And I'm wondering if there were some lessons that you could have somebody reach back and say, well, what is it that they did? Because one of the things that you said to Mr. Moran is that you're looking for ways to incentivize inside the VA. Why hadn't that been done? We've been hearing that. And as I understand, there's now legislation that allows people who have been less than performing to be fired. There's nothing revolutionary about that. But apparently it takes legislation on it. And last year, this committee put on an amendment, and it passed the full floor of the House, that said if the VA did not clean up its backlog, there would be a 25% reduction in salary on the administration level. So we're all, united together to find that magic incentive, but I'm just wondering what's keeping it from happening? And again, I'm not directing this towards you, but towards all of us who have sat in these chairs over the years.
I don't know that I can speak for the Veterans Administration, but I would respond by saying that we have looked at all of the incentives and where the industry goes to try and promote wellness and modify behavior and try and encourage the right use of health care. And those are incorporated in the proposal that we have put forward.
And along that line, have you sat down with the VSOs? And because I know that in terms of the healthcare and the VA, it's still the same kind of issues that we're facing. But have you sat down with the VSOs to discuss this? And can you get their buy-in?
Well, we have engaged repetitively with the VSOs, and we know that they're not happy about increasing fees. I will say that over the last few years, as we have talked to them, one of the things that they've repetitively told us is that we needed to produce a more efficient administration to wring cost and inefficiency out of that. And I think we've responded to that with the establishment of the Defense Health Agency, which I think is historic, in trying to make sure that we have the most efficient, most effective, lowest cost administrative organization as possible. So I think we have responded to that.
And would you say that, say, 2 years from now, 3 years from now, there will be a difference that you can say, I did that, I bent that cost curve, which Mr. Moran has mentioned? And again, it is astounding that since 2000, military personnel has decreased 10%, but the costs have doubled. And so I think that's what we're all frustrated about it, because we all share the same goal. We want the quality, the best health care. It's extremely important to take care of our military personnel, but also this cost issue is just...
So direct answer to that question, yes, I can say that in the future, and actually now, we have started bending the cost curve. As I mentioned before, we're saving about $3 billion a year. So we have federal ceiling pricing, we have prospective payment systems, readjusted programs to save millions, if not billions of dollars. The pharmacy changes alone have yielded $7 billion in the last 4 to 5 years. So we are working very hard, and that's why I mentioned before, we're pedaling pretty hard. But even when we're doing that, because the top line of the Department of Defense is coming down, we become a greater percentage of the cost, and we compete in terms of training, manning, equipping, and modernizing the force.
Thank you. Thank you, Mr. Chairman.
Thank you, Mr. Kingston. Ms. McCullum.
Thank you, Mr. Chair. I'm going to switch the topic here a little bit. You work with so much, you cover so much, but one of the things that I've been interested in, and I mentioned with you when I was out at the Army, my father had malaria, so kind of paying attention to those kinds of long-term diseases and the effects that it has on people, not only when they're serving, but when they come home, can be pretty impactful. So what's going on with tropical diseases is what I'd like to focus on a little bit. U.S. servicemen and women, they're often deployed to tropical disease epidemic regions. We have, with the extension of AFRICOM now, the look to the Pacific with some of the islands and that we're going to find our servicemen and women at. I think this becomes very impactful. In 2003, malaria impacted Marines deployed to Liberia. It affected 80 out of 220 Marines. The number of person days lost among U.S. military personnel due to malaria, just malaria, during every military campaign fought in malaria epidemic regions during the 21st century, it's alarming. Humanitarian missions that our military are often on in some of these regions, too, also place Americans at risk of infectious diseases. Evidenced by several Americans contracting malaria while supporting the Haiti and Philippines efforts. So reducing the risk of malaria is one thing in which you have a proud history of working on, but there's many, many other diseases that are being presented to servicemen and women, and it's critical in your mission to succeed in finding ways to either prevent or to treat. So, I can't stress enough our role, your role, the government's role in what we've done on diseases in the past. So we know we have problems with drugs and prophylactics used to keep our men and women safe from these tropical disease regions. And sometimes they're not reliable, sometimes they don't exist, and sometimes the side effects are such that it's very hard to get people to comply with correct usage and dosage. So I'm going to ask you a couple of questions here, but for folks here, dengue fever is something that is spreading throughout It's just not in Asia anymore. It's in Africa. It's in Central America, not too far from our doorsteps, and maybe possibly in Texas and in Florida with climate change. I'm not going to say this right, but I'm going to give it a shot. Chinkachungagaya? All right, you guys got it. But it's another, as dengue fever, it's another mosquito. And, you know, you look at the charts, it's all over Africa, it's in India, and it's all over in Asia. It seems to somehow or another, as of yet, missed Australia. But, you know, they're probably paying attention to what's going on, too. So in what you are talking about with, you know, getting right-sized, making the decisions on how to make sure that medical costs are given in a way that is strategic, that treats the illness, that treats the disease, but isn't overtaxing the taxpayer. With our world changing, with our climate changing, you're still confronted with a lot of these tropical diseases. So what are you doing to, you know, continue to prioritize the R&D for the tools to combat these neglected and tropical diseases to ensure that we're prepared, our servicemen and women are prepared? I mean, you cannot lose that many people down with, when you have dengue fever, you don't move. And there's no treatment for it at all. And if it was to have an outbreak on a military ship or some Marines or some Army folks in AFRICOM deployed, you know, what are we going to do about it? So what do we need to know about what you have to continue moving forward in your R&D on these diseases?
Let me make one comment, and then I'm going to turn it over to the Surgeon Generals who can really speak to this. We do have a robust program in infectious disease to include all of those diseases that you mentioned, and we have a network of overseas labs. But I think the Surgeon Generals really can speak to this effectively.
Okay. Thank you, ma'am, for the question. I just recently returned from Thailand looking at one of our labs, Eucerium Labs, that really has tremendous focus in the area of malaria and disease preventions within the Asia area. And right now we're in phase 3 clinical trials for a vaccine prevention for malaria, which is looking very, very promising. We're spending and focusing our efforts on not just prevention, but also looking at the oral prevention and trying to find other alternative medications that have less side effects than some of the ones that are there today. And so I know we're working very collaboratively with the Navy where they've got research, and I'll allow Matt to comment.
Yes, ma'am. Your point's very well taken, because we're putting people on ventilators in the States that started from an infection in poultry in Southeast Asia. And so this is a worldwide threat and globally emerging infections. And we're front and center on the readiness aspect of it, of the deleterious effects to our troops. We quiz medical students, we ask them, what's the deadliest animal in the world? And they come up with snake or bear or tiger, and it's the mosquito. It kills more people per year than any other animal on the planet. As General Horoho said, there's amazing strides being made in vaccines, and hopefully within the next few years we'll have a viable vaccine for malaria, especially as drug-resistant malaria is now starting to emerge in Southeast Asia, which has no known treatment. The bird flus, avian influenzas, the H1N1s, the H5N5s, they're starting to emerge. We're on scene with the Army. I just got back from Singapore, Cambodia, and Vietnam, where we have very robust epicenters of study going on collaboratively, which not only proffer global engagement and partnerships and diplomacy, but are creating world-class science that perhaps can nip these in the bud. The Navy has the only military base in South America is a Navy research base in Lima, Peru. We also have Cairo, Egypt, which has been running uninterrupted for the last 50 years, as well as now in Singapore, Cambodia, and Southeast Asia. And the Army has a very robust in the Thailands thing. So to answer your question, I think we're leaning forward on this. We recognize the threat not only to our personnel, but to the world citizenry at large. And we're very interested in trying to make headway on this and gain partnerships and trust of other nations as we do it.
Thank you, Ms. McCollum. Mr. Crenshaw.
Thank you, Mr. Chairman. Just following up on that, when you mentioned you're doing research for a vaccine, and I know you've been working on that, but you mentioned a couple of years. Do you have any idea, I mean, more specifically, when you think you might have a vaccine? Because I know that it's being tested. Is that a year, 2 years, or what?
Well, they've just recently come up with a vaccine that provides, for the first time, 100% immunity. The challenge is that malaria, a little bit like viruses, can morph, and there's 4 distinct types. Finding one that will reach the necessary titers and the efficacy, and field testing it. We've already used it on human subjects, and it's been proven to be effective in our human lab subjects. We'll see what happens as they expand now to the more native areas. To answer your question, sir, I'm told by our research experts, and Patty, correct me if I'm wrong, but they really think they're within a few years of finding one that may be commercial.
And can you, like, it seems we're talking about healthcare costs and how that's a big part of our personnel and how the personnel costs are kind of impacting readiness. I mean, so it's an important conversation to have. I think you all are essential. And we talked some about the outside, about how you share the cost, but I think we're talking more about how we can lower the cost of health care. One of the things I would think, if you had a vaccine as opposed to some anti-malarial drug, there probably is a quantifiable cost savings if you could deal with that. It's preventable. You can have a net and all those kind of things, and you can take drug. But if you could actually have a vaccine, it seems like that's something would be a way to save money in the big picture in terms of health care. Is that right? I mean, I don't know if you tried to quantify that, but
Absolutely, sir. An ounce of prevention is worth a pound of cure. I will add, as you know, administratively and the bureaucracy of putting new medications or novel medications out into general use to go through the wickets, often which are protective, but it can be substantial, and that's where some of the time comes from, to meet all the requirements of testing.
because let me follow up on that. I mean, I know there's some partnerships that y'all, I don't know if y'all are familiar with. I met with Colonel Craig Shriver. He's the director of the Murtha Cancer Center. It's at Walter Reed, and I think John Murtha, who we all know and love, his legacy lives on in cancer research, and that's one of the areas that I was talking to Colonel Shriver about. That they've got a partnership with what's called the Moffitt Cancer Center, and they're doing a lot of research to work together, dealing with prostate cancer and lung cancer. And one of the major benefits, as I understand, they were explained to me that if they can take you've got a great reservoir of populations and centralized medical systems. They've got the doctors, and as you work together, you can figure out what cancers require treatment, what cancers are more benign and don't need treatment. And then that knowledge can reduce not only treatment costs, but it can improve the quality of life of the people involved. And so I don't know how familiar you all are with that partnership with the Moffitt Cancer Center, maybe Dr. Woodson, but if you do, talk a little bit about how that's bringing down the overall cost as you do that. But if you're not familiar with specifically, what's your view of this leveraging taxpayers' dollars in terms of medical research, using outside groups like that to work with you to ultimately lower the cost for everybody?
I couldn't agree with you more. And if you remember back to my opening statement, I talked about one of my 6 lines of effort is defining and investing in strategic partners. It's absolutely necessary. And so one of the ways we've gone recently is consortium to bring the best and the brightest, best talent, wherever it might be, into the picture to solve the problem. I don't know, General Horoho, do you have anything?
Thank you, sir. There is much that is being done in the area of partnership. So as we look at what is the military relevancy of different scientific research that needs to be done, there's government dollars that are put towards it, but a majority of the dollars really are the partnership that we have with civilian institutions that are out there, because there's usually a civilian relevancy along with our military relevancy when we're looking in the area of healthcare. You could look at what's being done with regenerative medicine. We're now on the 2nd consortium. Much of the transplant, both the hands and our face transplant, has come out of that consortium. There's work, tremendous work that's being done in cancer research, in autism, in neurotrauma, just across the board. And so Bill Gates, that foundation, there is no way, I think, in the environment that we're in, that we could do the relevancy of the research that needs to be done without the partnership within the civilian community. I think it's vital.
Thank you.
Could I add one more comment? Just on the partnership thing, and I alluded to this in my opening comment as well. For years, we've been doing trauma training with university partnerships, University of Cincinnati, St. Louis, Baltimore Shock Trauma right up the road, who provided trauma training for folks who were just about to deploy, hundreds of them, so that they get the trauma experience, trauma exposure. But the side effect of that is because we have persistent presence and staff in those trauma centers, there's also tremendous research going on with their university partners that could not occur just on our own budget.
Well, we're assuming, and Mr. Crenshaw's time is up, but let me put my oar in the water here, that you are intimately aware of these investments from congressionally directed medical understanding. So we assume you are. So, Mr. Owens, thank you for patience.
Thank you, Mr. Chairman. Thank you for coming today to testify. Dr. Woodson, does DOD suffer from a shortage of mental health professionals, whether it's psychiatrists, psychologists, or psychiatric social workers?
Our fill rate for psychiatrists is about 91%. Overall, for all behavioral health specialists, we're tracking at about 102%, but that's because we're able to fill certain behavioral health specialists in excess, like clinical psychologists, at 124%. Short answer is that we do have deficiencies in certain areas, and these tend to be the hard professionals to recruit because they're in demand throughout the nation.
And are you recruiting primarily for civilian participation as opposed to service member participation in those occupations?
So, yeah, I think it's both. We want to make sure that we have the right professionals to provide service to our members.
In rural areas, in which many military installations are located, I happen to have Fort Drum in my district. Is that an issue that is more prevalent in those geographic areas than it would be in an urban or suburban setting?
Absolutely. And to try and mitigate and deal with this, as we talk about what should be our 21st century capabilities, we're trying to invest heavily in telebehavioral health so that consultation can be provided even in rural or more austere environments.
Thank you. General Horoho, are you familiar with the Fort Drum Regional Health Planning Organization?
Yes, sir.
What's the Army's position relative to that organization?
Back in 2010, I believe, the funding stopped for that organization. And so in the past, it was a very close relationship with the Army in looking at how do we maximize the civilian health care around the Fort Drum community to meet access to care and ensure continuity of care. And so what we rely on right now is really looking at the TRICARE partners within the Fort Drum community to ensure that we're trying to meet those needs.
And that's because Fort Drum does not have a hospital facility on the post.
We don't have inpatient. We have a hospital facility, but we don't have inpatient care, the subspecialty.
My ultimate question is there something that we can do to get the Army or DOD to re-engage with the health planning organization and to provide funding for it?
I would have to refer over since that's with DOD.
We would be happy to look at the affiliation and the need for services. Yeah, I mean, if there's a need, yeah, absolutely, we'll talk.
I think certainly my perception is, and I think those folks at Fort Drum clearly think that there is a need for that assistance. And New York State is going through, and in particular in my region, a healthcare redesign commission. I happen to be an advisory member of that group, and for us, this has regional impact as well. So I would hope that we could facilitate both military health care and the local community's health care. Thank you. I yield back.
You're right. And we always value what you have to say. Ms. Lowy.
Well, you're very, very kind, and I apologize that we seem to be having 3 or 4 hearings at the same time, and I know that your presentation has been invaluable, and it is my loss. I'm sorry that I have not been able to be here for the entire hearing. One of my concerns, and as I gather, I know it's the concerns of many of my colleagues, but it hasn't been discussed as yet, is after 13 years of war, the invisible wounds have been among the hardest to comprehend and to treat. I'd be most appreciative if each of you could share your efforts to treat these invisible wounds over the past 2 wars and in a post-war climate. The committee has added funding above the request dating back to 2004. If you could focus on how the funding has helped advance treatment in the areas of psychological health, traumatic brain injury. If you could each give a brief description of your respective service efforts to reduce the number of suicides. What program is the most effective? What would you do differently if you had more funding dedicated to suicide prevention efforts? And what are you doing to help your service members cope with the anxiety of the personnel drawdowns and the anticipated slower tempo? Maybe I'll stop at that, but I think this is an issue that we are all dealing with in our communities. And when I have seen families distraught from this, I can just imagine the personal pain that they are enduring themselves. So if you could each discuss that, I'd be most appreciative.
Thank you, ma'am, very much for that question. So if I could start first in kind of the strategic, and I'll narrow it all the way down. So the overall culture change that we had across our Army has been over the last couple years, and we really have made a culture shift of focusing more on readiness and resiliency. And what we found is over the start of the war and throughout with the robust funding is that we had many programs that were developed because the funding was there and these programs were developed to meet the needs. And what we needed to do is to look and start evaluating the effectiveness of the programs and get more proactive than reactive. And so that has been a fundamental shift. And we have started to synchronize installation command as well as MedCom, as well as our personnel community to look at policy programs and resources and actually have metrics where we evaluate the programs. So that is the overall Readiness and Resiliency Campaign plan. Then we also looked at synchronizing within the Readiness and Resiliency our performance triad of looking at sleep, activity, nutrition with the focus on brain health and having that synchronized with comprehensive soldier family fitness, with Army Fit, so that our efforts are not a medical effort, but it really is an effort that's pushed into the line community to look at health and wellness, because there is so much that is connected in that area if people are having PTSD and they're using alcohol to maybe fall asleep because of the nightmares, and you start having all of those bad outcomes. So we're trying to be very preventive and proactive in that area. So we have ongoing studies at Fort Bliss, Fort Lewis, Fort Bragg, and also in Afghanistan, looking at health outcomes associated with the performance triad. Then we've also stood up a behavioral health service line, which has standardized behavioral health across every platform and touch point in which we provide behavioral health care. We started out with 211 programs. We narrowed them down to 11 enterprise-wide behavioral health programs, and then we rolled out a behavioral health data portal, which is the first time ever we're looking at health outcomes to truly evaluate how effectiveness our behavioral health is. And then the Air Force and the Army the Navy is actually adopting that behavioral health portal as well. And then we've combined that with the use of telebehavioral health. So we provide behavioral health care using telebehavioral health over 19 different time zones. That has allowed us to actually double the amount of behavioral health being provided. And so we are starting to see with embedded behavioral health, which we have actually pushed our behavioral health providers into the Garrison footprint. We're seeing a decrease in inpatient behavioral health admissions. We're seeing an increase in health outcomes in the area of behavioral health, and then we've trained all of our primary care providers in behavioral health. So it's truly a system moving into that area.
Just if I can pursue that for a moment, you're talking about identifying the problems while they're in active duty. One of our concerns, I'm sure when I was gone, you were talking about the lack of an integrated medical record system.
We have yet to get into it, but we're definitely going to get into it before we leave here, I can assure you. They're on alert, Ms. Lowy, I can assure you.
Okay, so I'll leave that for someone else. But on this particular area, what we have found, and although it seems to be getting better, but I know so much of the problems that occur after the person is transitioned, after the person is a veteran, and most of the problems are blamed on Secretary Shinseki. However, no matter how many times we bring it up, no matter how many times we talk about it, it's been months, Mr. Chairman, is that correct? We still don't have an integrated...
It's about 7 or 8 years, actually. It's been too long, but we're going to focus on it. We're going to get some answers before they leave here.
So what I wonder about on this particular area, if these problems are identified before the person leaves active duty, are they followed into the next phase of their life? Are they continuing to get this service? I hear no, but I'd be most appreciative if you can tell us some good things, as with the chair.
Okay.
We're going to extract those answers out of them before they leave here. Is that all right?
Okay, that's fine.
Okay. Thank you, Ms. Lowy. Mr. Womack.
So many questions, so little time. And I want to thank the panel for their service to our country and what they're doing. Earlier in the testimony, in the Q&A, there was reference made to what we're doing given the increased cost of having to treat those that have been so courageous, have gone down range and served their country in uniform. Simple question. No matter what you do, no matter what best management practices we use, no matter what we do to leverage technology, do we still have a simple math problem in that there are more people that have served our country in uniform that are going to be subject to the care, the promised care that we've made to our servicemen and women? Do we just simply have a math problem right now? Dr. Woodson?
In part, it's a math problem because people live longer, and so they will utilize the benefit for a longer period of time. In part, it's a math problem because 5, 6, 7 years ago, the number of eligible beneficiaries that took advantage of TRICARE was about 62%. It's now about 84%, and we expect some rise to around 90%. And then in part, it's
excuse me, what were the percentages of?
Sorry?
What was the whole of the percentages?
About 84% of eligible beneficiaries use the TRICARE. So in part it's a math problem, but also it's a delivery of care strategy as well. So both. Yeah.
For our panel in uniform, this committee has had a number of briefings and hearings, and at the very core of our concern is our nation's readiness in uniform. And so we have, in kind of descending from this, for this long period of time where we have had an elevated state of readiness because of the multiple deployments of our men and women going through in uniform, as we start to descend from that operational tempo, are you a bit concerned about our capacity to keep our men and women in uniform ready medically, and specifically our Guard and Reserve folks who have had unprecedented levels of medical readiness in this time frame? General?
Sir, great question. I'm very concerned about it. I think we all are. We talk about it all the time. I say frequently in public forum, war is a hell of a readiness platform because you stay trained, you focus on war. It's great motivation to get training and be out there and doing the job. As we come home from this war, and it's not done, as the Chairman alluded to, I think the opportunities to really have that exposure and are going to be waning, diminishing. When I go into an MTF these days and I say, how many of you deployed? 70% of the hands go up. In 5 years, it's not going to be that many. And then that's why I made a comment in the opening that I'm worried about us not being as ready at the next one as we are right now for this one. So the issue is, even as we're trying to find ways to save money, and we're looking within our own direct care system to do that, frankly, we don't need to be chopping the direct care system that much because we still have to have the opportunity to practice, not just doctors, but nurses, technicians, and the rest. With regard to the reserves, as you may know, for us, the AirVac system, 60% of our AirVac mission is reserve, and they're performing magnificently. So how do you keep them, number one, clinically engaged as this war winds down, but then also exposure to care in the air? And of course, whatever we do in the future, because we've proven now that it's not just how many beds you have in theater. In fact, it's not how many beds you have in theater. It's actually how quickly you can transit people back to the right level of care. We've transformed how we do medical care in war these days. So all I'm doing is, I guess, sir, is endorsing your worry, and we have all, to include the Secretary, kind of strap this on and try to think of transformational ways that we can keep our folks clinically engaged. And again, our partners will be very important in that, but also figure out how to leverage each other's strengths, as we're doing now more in an interoperable way than we've ever done.
Well, far too often we consider readiness to be more of a move, shoot, and communicate and prosecute war, but so much of it is based on a platform of medical readiness from the get-go. And if I could for just a couple of seconds, last year I consider the testimony or the example, General Horoho, that you gave regarding Sergeant Brendan Morocco one of the most incredible things I've ever witnessed in life. And so maybe a little bit later on you could kind of update us on that young man's situation, who became, I think, the first soldier who had quadruple amputations to be the recipient of double arm and or double hand transplant surgery, and I'll leave it there. It's an incredible, riveting story, and I thank you for it. Mr. Chairman, I yield back.
None of us will ever forget it, but you will update us a little before we leave here. The gentleman from Alabama, and then Mr. Ryan. Mr. Adderholt.
Thank you for all being here this afternoon. Dr. Woodson, in your submitted testimony, it appears that cost-sharing fees have been split between the ranks of E4 and below and E5 and above. The concern is an E5 would pay the same cost share as an 06 when the difference in base pay salaries between the two ranks is around $7,000 per month when you factor in typical service years. Can you elaborate to us on how the Department determined that the cost share program should be split at the ranks of E4 and E5, and why there are two cost share categories, given that there are a total of 24 ranks in the military and the base pay salaries range from $1,500 a month to $15,000 depending on the rank?
This is an excellent question, and the reason it's excellent, it gets to the issue of fairness and how you make it equitable, and then how you actually administer a program if you have to constantly check grade status, income, etc. I think that the service chiefs and the senior enlisted folks who had great input into this looked at it and I would remind you again that in last year and the year before, when we made proposals, we tried to break out even greater tiers, looking at sort of ranks and the sort of categories you've indicated. The bottom line is at some point you come to a decision about what you think is fair, equitable, and doesn't produce an undue burden. So, for example, with the E4 and below, the majority of those individuals, including their family members, have access to MTF care, which means that they could have extremely low cost and no cost care. So if you look at the numbers of folks in that grade that use TRICARE Prime Remote, which would be an indicator that they're away from the MTFs, it turns out to be an extraordinarily low number, less than 2%. So when you look at sort of the distribution of folks and then you try and devise a program that you can administer, and you get the input of the service chiefs and the senior enlisted, this was a proposal we came up with. But your point is well taken.
Thank you. That's all I have.
Excellent question. Concerns all of us. Mr. Ryan.
Thank you, Mr. Chairman. Apologize for being late on the budget markup, and as you know, that could be a marathon. Not a good one, if there is such a thing.
You serve on the
good.
Budget Committee?
I do.
Our sympathies to you.
Thank you, Mr. Chairman. Two topics, two questions. One is regarding mindfulness-based relapse prevention, which is a approach that the military is implementing. And I just want to share with you a study that has just come out with regard to cognitive behavioral relapse prevention and mindfulness-based relapse prevention. And the study, both techniques were shown to reduce substance abuse treatment. The cognitive behavioral relapse prevention went about 6 months and was still effective. The mindfulness-based relapse prevention went up to a year to be found as extremely effective in reducing incidence and reducing drug use days and heavy drinking. I think these are effective techniques. I've been researching them for a long time. I think they're something that we need to continue to promote within the military, but also in the VA. And coincidentally enough, Monday I got a letter from a woman who said her husband's an E5 in the Army, receives behavioral health treatments in the form of counseling medication for depression, anxiety, PTSD symptoms, and sleep disturbances. Long story short, he couldn't get into the mindfulness-based relapse program, got into the program, and saw significant improvements, reduction in medication. And so I just want to encourage you to help push down throughout the bureaucracy of the military these type of techniques. They're working. It's not medication. It's not as easy to just put someone on to put someone on a prescription to try to help them, when these other techniques are extremely effective in dealing with their brain chemistry, their nervous system, helping them become more aware of incidents. And it's a huge issue. And so I'm asking you to please look into these mindfulness-based techniques. There's a mindfulness-based mental resiliency training that the Marines are doing on the front end to help build resiliency, which I think is as important for helping the men and women in our military to deal with this. But then also, if they need the help, get this kind of treatment. And then hopefully you can work with us. We have an Armed Services Health Promotion Act, which is both the defense side and the VA side, to push out further integrative health techniques. I think it's extremely important. It can save us a lot of money in the long run. It's not about medication. The other issue that I'm very concerned about with the military is the issue of obesity. We have 59% of the Air Force personnel are classified as overweight. 17% of sailors are obese, while 62% are overweight. And you know as well as I do that being overweight, being obese leads to diabetes. We have 1 in 4 vets that are diabetic today. And I've been to different facilities and I see the food. A lot of this is caused by the processed food that our men and women are eating. I'm just thinking if we can find certain issues as a committee, Democrats and Republicans, that we can agree on. Diabetes is going to cost our country $245 billion. That's up from $174 billion just 4 or 5 years ago. And to think about, that's as a society, not in the military, but to think of a common ground piece of legislation that we can work on with you. I know the NIH is doing a very big comprehensive Healthy Communities initiative. I know there's a Healthy Base initiative, but I think there needs to be a partnership, and this needs to be accelerated. It's a great opportunity for us to come together on the front end to do prevention. So I know I took up a lot of time here, Mr. Chairman, and I don't necessarily have a question other than can you help us maybe piggyback on the NIH study and help us expand the Healthy Base Initiative program, and I think drive down costs. You talk about food, you talk about mental health promotion and all the like. So take a shot at it in the minute that we have left. General, if you could, or...
Sir, you just hit my passion, and that's exactly what we've been doing over the last 2 years, is really moving towards improving health outcomes. And so we have seen with the wellness centers that we've been rolling out, we've seen a 4% decrease in body mass index. That's 62% of those that have gone to the wellness centers. That's just one touch point as we partner with the Healthy Base Initiative that's occurring across Department of Defense, but really looking at educating on nutrition, educating on the value of sleep, because that's tied to obesity and weight gain, as well as other stress indicators, and then really looking at activity. And so our pilot programs that we have going on right now is also being done with a research study to evaluate not just health outcomes, but also where we're having cost savings.
Well, I'd like to work with you on the food piece, maybe on the ships and on the bases and what's even available. And then in the wellness centers, I think these mindfulness-based techniques could be extremely helpful. And you do that in the wellness? Can you talk about that for 30 seconds?
That's part of what we've integrated in our wellness centers, as well as what we're doing with our performance triad in our patient-centered medical homes that are rolled out across, is alternative integrative medicine. We're using mindfulness, acupressure, acupuncture, cognitive therapy, and so we're looking at multiple tools that individuals can choose from to kind of help them improve and decrease the reliance on pharmaceuticals. And we've already seen a 50% decrease in our pharmaceuticals just out of our patient-centered medical homes that have this integrated approach.
Nice. Mr. Chairman, I know I mentioned to you about the Armed Forces bill that takes both defense and the VA. I think this is an opportunity for us to amplify what you're doing and talk a little bit about how we have this continuous coverage into the VA and drive down costs. I think there's a great opportunity here, Mr. Chairman. Well, I look forward to working with you to make it happen.
Well, thank you, Mr. Ryan. We know you was alarmed by those Air Force figures, so, General, I can't have many wings up if we have that many people that are overweight. I'm going to deny you a chance to give equal time.
I have no comment.
Good.
Yeah.
But Mr. Ryan is on his game, and we turn to the gentleman from Texas who probably has more of our fine servicemen and women in his congressional district than any other. Judge Carter.
Thank you, Mr. Chairman. I'm going to ask you the question that I get asked constantly. It is the #1 question I get asked by privates and generals, active duty and retired. It's a tough question. As you look down the corridors of the future in medicine, military medicine, considering our rising debt and the rising cost of medical care, do you foresee a time in the future when TRICARE or TRICARE for Life or VA or all of the above medical care will be abolished or converted into such a manner that our active duty military and retired military and their families will be moved into the Affordable Care Act or Medicare or Medicaid or a combination of the above as a substitute or replacement for their current health care?
Thanks for that question. The short answer is no. The nuanced answer is that, of course, 65-year and older retirees use Medicare and TRICARE for Life, so they are in Medicare. I think that Congress and the American public want to always ensure that those that raise their right hand and promise to protect and defend get a robust benefit. in terms of health. I do think, however, that as we go forward collectively, we've got to rationalize the program. So right now, in a retiree, the American public pays for 3 different types of access to care. They pay for the TRICARE benefit, they pay for the direct care system, and they pay for the VA system. And so at some point, I think we need to look at making sure that we ensure that they have care. 2 of those are free now at this time, but we're going to have to rationalize it a little bit to make sure that we can sustain it. But I don't see a draconian way of going to the Affordable Care, because remember, that's a premium-based system anyway, and that's not what the benefit is all about.
Anybody else want to answer?
Sir, we get that question as well a lot. One of the reasons that we've had a orbital improvement in combat casualty care is because of the organic standalone military health system and the trained personnel who operate within it. We could never buy as many providers, nurses, technicians as we can train and cultivate in our own MHS system. And that includes the direct care system and partnerships with our academic, sometimes very pristine academic partners. In order to be able to maintain, train, and keep the skills currency to provide the kind of care that the American public has come to expect from the battlefield or from the sea or from the air, we have to continue to see and utilize and practice and treat that patient population. Without it, our training programs would go fallow, and we would lose. Many people ask, well, don't you just need combat trauma personnel for war? We do, but in order to train those and provide those, they must be integral into programs that have internal medicine, that have pediatrics, that have OBGYN. And so we run the full gamut of care in our facilities, not only to take care of our families and maintain family readiness, but also to field the kind of team that right now is as General Travis mentioned, a little bit tired, a little bit worn out, and getting ready to take a knee, but nonetheless, the best and highest professional trained quality medical force the country has seen. So we are greedy to hold on to that population.
And I understand those people are currently serving. I think the future is the one they're worried about when they are no longer currently serving the military. They've retired from the military, but they feel like they've contracted for the future with TRICARE for Life and with Medicare. I do recognize Medicare.
If we don't take care of the retired population in that age group, we can't train and maintain the critical mass of our training hospitals.
So I'm waiting for the answer, no.
The answer is, from my perspective, I think I speak for all of us, no. We do not.
Because that's the answer they want, and I'm asking you to help me give it to them.
We are not going to disenfranchise that population.
Agree with no.
Okay, then I'm going to tell them no. I got one more question, Mr. Chairman. I've been in Congress for 12 years, and in that 12-year period of time, we've talked about what Ms. Lowy raised, the communication between DOD and VA. So I want to ask a question. In the effort to allow DOD and VA medical record systems to communicate, DOD and VA are now developing different systems and attempting to develop applications that will work between them. Has the DOD and VA considered, rather than focusing on the system themselves, focusing on the basic operating parameters, a database language? With a standard like this, DOD, VA, and any other applications running on the same standard would be able to easily communicate. This is a model used frequently in the private sector software and platform development. Has that been considered?
So let me answer that. And again, the short answer is yes. And in fact, we've done a lot within 2013 to actually do that. One of the problems with electronic health records is, in fact, there wasn't common nomenclature and standards, and so we've been working with the Office of the National Coordinator to create and enforce those standards. So we made great progress in 2013 in mapping between DOD and VA the common terms and standards so that we can create interoperability. and we have deployed to 9 sites where we're actively taking care of DoD and VA patients this new, this joint legacy viewer to integrate the record, and I'd be happy to show any of you a demo video of how this works. So the other thing we've done, we accomplished by the end of 2013, is we're no longer transferring paper, the service treatment record and paper to the VA, because we have an entirely electronic means of transferring those records. So it's been slow, but we made great progress in 2013, and in 2014 we're looking at the scalability. So the answer is definitely yes.
Will the gentleman yield?
Yes.
Yeah. Is currently the Department of Defense and the VA using separate medical databases that can neither translate nor communicate their data in a functional way currently?
So we are mapping all of the VA data to the...
Are you using separate databases?
We are mapping all of the data to the health database, so the VA is mapping all of their data to our database at this time. Yeah.
So you are indeed making some progress.
We are making progress.
We have invested so much money in this. I mean, the whole issue of raised expectations. One year we blame the VA, then the next year we blame the Department of Defense. I mean, you all with wonderful, records and dedication to the country must be enormously frustrated and to some extent embarrassed by this situation here. I mean, you don't have to. I can look at your responses, which are not recorded, but let me say, we need to make some progress on this. Back to you, Judge Carter.
Well, if I have time for one more question, this is kind of personal. NIH maintains a database of undiagnosed diseases, and you talked about some today that I never heard of. I have legislation that would encourage them to open that database to third-party physicians to increase the catalog of symptoms and provide resources to the medical professionals who are trying to identify an unknown illness. Does DoD have any similar database, and is there a way you can think of that DoD might be able to contribute to this effort? We have an awful lot of mothers who've come to me and said, my baby's dying, there's bound to be somebody else with these symptoms, I sure would like to talk to them.
So again, I think you're spot on, and across the federal space and to some extent in the civilian space, in the research community, we are opening these databases and contributing to the same databases to drive to more effectively to answers to some of these desperate problems.
So you're saying DoD would be associated with NIH's database?
Yes, and we already are, several right now, so yes, absolutely.
Thank you, Judge Carter. Epitomizing patience, Ms. Kaptur.
Thank you, Mr. Chairman, very much. I could say the same of you. You have to listen to all of us. Thank you very much for your service to our country and for coming today, as with our other colleagues, Mrs. Lowy and Congressman Ryan and others, Congressman Womack. I have a deep interest in psychological, behavioral health, and human performance. We, over the past several years, the Congress has added substantial resources for psychological health research and traumatic brain injury. And one observation I have of all of your testimonies is that understanding the incredible role that the Guard and Reserve have played in our warfighting over the last decade, the absence of significant mention by each of you in your testimony is troubling to me. They are a understudied, most vulnerable, less supported subgroup within our military. And the first homework I'm going to suggest is that you take a very close look at something called the Ohio Army National Guard Mental Health Initiative. Obviously, we each come from different places. I don't have a big base like Fort Hood, but I have soldiers that have fought nobly. And my questions, and I'd like to make some further clarification for the record, but my questions really are, how are you managing the research, diagnosis, and treatment of the psychological health of our warriors and veteran population. Dr. Horoho, on page 8 of your testimony, you reference on August 2013 a National Research Action Plan that the White House released, and you mention various entities of our federal government involved in that. And then on page 21, you talk about suicides, and you use the word several times, active duty, active duty, active duty. I am very, very concerned about what I see happening in Ohio, and my concerns may be misplaced, but for a number of years we have been trying to help our returning soldiers. And we have developed a 3,000-person minimum database with DNA samples and so forth. But what's happened inside the Department of Defense is unbelievable. In trying to help our Guard and Reserve, first we started out in something called the Military Operational Medicine Research Program. And somehow, as the research progressed, and I believe it to be the only longitudinal study that I've seen in the country of what actually happens to these individuals on rotation out, they've been switched to something called the Warfighter account. And I am really perplexed and not understanding the plan of the U.S. military for a comprehensive approach to diagnosis and treatment and long-term observation of these individuals, and also invention of new methodologies to help them lead a more normal life. So I'm asking each of you, can you explain to me what this shift in placement within DoD means? Is it more helpful to the Guard and Reserve or less helpful? And how do we embrace the Guard and Reserve across this country who do not return to a home base when they do have, and over time, these behavioral issues continue to well up?
Thank you for the question and pointing out the concern. And I would say, for the record, that I think each of us deeply appreciate the reserve component and pay attention to the reserve component. In fact, in my opening statement, as I talked about medical force, it is about understanding the balance in the active and the reserve components and what we need to do to reform policies and procedures to promote, protect, and support them. And I'm a reservist who has been mobilized many times, so I've felt it in many different ways. Now, to get to your point about support for psychological health, we have a number of activities, and I'm sure the Surgeon Generals will elaborate, that looks at pre-deployment, post-deployment, and a series of follow-up examinations to ensure that we're capturing those that might have difficulties. We've invested with the VA in a longitudinal integrated mental health strategy to provide the best clinical practice guidelines and the warm handoff to the VA for those individuals who have psychological, traumatic brain, or other mental health issues. We have invested with the VA in telebehavioral health so that we can extend our capability to reserve components and folks who are remotely located. And we've invested with the VA and the National Guard in state coordinators to help arrange for the needs of the reserve components. And then there are a number of other programs like Yellow Ribbon and the like. So I'll stop there and I'll let
Dr. Woodson, could I just mention something here? We're having a separate fight over in the Veterans Committee of the House to work with our state veterans' homes. There are only 2 in Ohio, but many around the country, to allow empty wings to be used for some of these individuals. Guess what? The VA fights us every step of the way at the national level. The local people know it's needed. We have homeless vets all over the place. Can't get it together. We can't get it together. All these roadblocks. And so people are under bridges, they're in jails, they're in all these horrendous conditions. And I'm just making you aware, because maybe if you talk to the VA, you can help them see a way forward. We're going to get through this. We're going to do this. We're going to provide decent shelter to these vets. But they need behavioral health care.
Thank you, ma'am, for the opportunity to kind of comment. And so if I could go back to your first statement of not including or mentioning directly the Reserve and the National Guard. Through my statement, when I use the word Army or total Army family, that includes the RC and the National Guard. And so I try.
So when you say active, you're including Guard?
No, so that's what I want to explain. So that's in the first part is talking about that. When I talk about the active and the specific programs in there, we had a phased approach as we've looked at changes within the behavioral health community and looked at improving health. We started first with the active component to see if the program worked. We're now in the phase of rolling that out within the Reserves and National Guard. So I'd like to take a moment to talk about that, if that's okay. Okay. So the first part of that is we are actually within the Reserves and the National Guard now rolling out our performance triad. We've tested it in the active component. We've now had agreement with the Reserves and the National Guard. They've given us 3 units each to be able to do pilot testing to see how this works, and so we are in the middle of rolling that out. We've also included them in, there's a MyPrime, which is an online computer database where our Reserve and our National Guard can actually go online when they're having difficulties or challenges so that they can reconnect into the community and we can direct them to resources and help. We've now actually have worked with the National Guard and the Reserves, and they've hired psychological health promotion officers so that every state has one, and then the reserve units are having that. So that is then one dedicated individual that is looking at the psychological health for our Reserve and our National Guard, and then being able to have consistent programs of the same that we've been trying to roll out across the active component. We've also partnered with Give an Hour in the National Guard, and I went to the kickoff with that, where Give an Hour is actually providing psychological help to partner with the National Guard to help through telebehavioral health, and so that has been rolling out across the National Guard states. We're also working with the Reserves and the National Guard in resiliency training, and they are part of our Readiness and Resilient campaign plan that has been rolled out across our Army. And so we are looking at all of those touch points from the treatment aspect, but more importantly now to the prevention and the long-term aspect of really providing the psychological health and the support.
Well, could you explain to me, what does it mean then when the Ohio Guard is shifted from the Military Operational Medicine Research Program to the Warfighter funding? What does that mean?
If I can take that one for record, because I don't have the right answer for you, but if I could take that, I'll dig into it.
I thank you very much for that. I wanted to say also that some of the results of the work that have been done relate to the largest amount of DNA that has been collected in the country for individuals presenting with these conditions. That in itself is a valuable national resource. In addition to that, we've learned many things. We've learned on enlistment, one of the top factors for those who ultimately develop these conditions is pre-existing experience with violence, more than 10 episodes. And so it has an impact on recruitment and on trying to make soldiers resilient for whatever they might deal with in the future. There's a lot of information that has come from this. I don't get the sense that it necessarily bubbles up. And so I'm appreciative of your taking a look at that. And I would be interested for Air Force and Navy if there is any information that you could give us today on what your branches are doing.
Yes, ma'am. One of our greatest challenges is trying to connect both the reservist and the individual augmentee with continuity of care, especially that of psychological health from either TBI or PTS. There are many programs out there, and many of them are joint. They can come across from military one source, and that's how people can find them. They often transcend the Army, the Air Force, the Navy programs. The challenge is getting the reservist who then leaves the fold to remain engaged or understand what's available to them. We have a couple of mechanisms for doing that. One is the Recovering Warrior Weekends. This is where reservists come back, they deactivate, and then they are given per diem and transportation to go to a city where we hold symposiums for 2 days at no cost to them. We encourage the entire family to come, at least the spouse. And then they are given 2 days of both some psychological assessments, some support groups, and mostly information on what's available to them both through the net, through the telephone, and through local reserve centers to get the care they need. So one thing, so it's been my experience that our biggest challenge is when we go to the reservist and they say we're failing, our family is failing, we're not doing well, we're having issues, they don't know what's available to them. So this was a mechanism which has been highly successful and been highly praised by the reservists who said, this has armed me with what I need to know to follow up. Even though I may be doing okay right now, but as you know, one of the challenges is 2 years from now, 3 years from now, 4 years from now, as people start having issues, how do they trigger help? We also have something called Focus on the Family, where we put for activated reservists and families. This is a myriad of facilities that are run out of our family services centers, and they come in, and that stands for Families Undergoing and Overcoming Stress, Focus on the Family. They can come in, see counselors, they can be given materials, they can be given referrals, and then to get to the larger question is how do we, and this gets to the chairman's point of a connected medical record, how do we provide a warm handoff from the DoD system to the VA system so that somebody's not lost in the process? And we're working very hard on trying to maintain databases now that we share with the VA. We're using lead coordinators for people who can, and federal health care coordinators who can not only watch the care as it's being given in our DoD system, but then they maintain the continuity of that patient, of that individual, as they leave our system and go to the VA system, so that there's somebody who's aware of their existence in both systems.
It was very interesting. One of our local sheriffs, and I represent several counties, he's a veteran, a Vietnam veteran, he said, you know, Congresswoman, he said, on every given day I have a minimum of 6% of my inmates who are veterans. He said, we've learned something interesting in the jail. We say to them, are you a veteran? They say no. But if we ask, have you ever had any military service? It's just so interesting how we work with people so that we are able to help them and we can unlock whatever is blocking sometimes their own ability to get care. I just placed that on the record, and
Okay.
we have one more reply.
I'll
Please,
keep
from
it brief. I know we're running short on time.
We're going to be here until I get a few answers.
Okay.
Respectfully.
Admiral Nathan's comments, I'd mimic those, but I would also tell you that for the Air Force, and we're a total Air Force, the Guard and the Reserves actually have established some of their own programs that are very good. There's a wingman toolkit the Reserve Command, I think it's Reserve Command, has put out, where you text WGTK to a number, and there's an app that will show up on your phone or a website that shows up on your phone. It's very accessible, works very well. The Guard has wingmen.org. From an active duty, on the active duty side, those of us who have more assets, mental health assets at our disposal, we actually have made a point of, in our laydown of the extra uniformed mental health providers that we are laying in as a result of NDAA 714 between now and 16, it started in 12, that we influenced our laydown of our mental health providers to bases where they could become reach back for what the Guard has now established as directors of psychological health at each of their wings. And so we've influenced where we put these, I wouldn't call them extra assets, but the assets that were mandated by law to make sure we're providing the reach back support to Guard units which may be more remote. And of course, we don't think we have quite the burden of PTS in our reserve forces as does the Army, but we recognize that there's a gap. We were trying to address that gap.
Thank you, General.
Thank you, Mr. Chairman.
We've been, as a committee, concerned about connection and continuity in the warm hand since 2008. So I have a few questions to Dr. Woodson. What is the medical database that the Department of Defense uses now?
The electronic health record is ALTA.
Yeah, and which stands, I may add, for Armed Forces Health Longitudinal Technology Application. I'm not sure what that tells us, but it's certainly a mouthful. It's not an acronym that I can remember. How does that system work?
It is based on a series of databases that archive and redistribute information. Of course, we have a worldwide network, so it's about archiving and redistributing information.
Well, tell me if I'm wrong. In February of last year, both departments, the Department of Veterans Affairs and the Department of Defense, announced instead of building one integrated health record, they would continue with their separate systems. Is that accurate?
No, not quite. What I think the statement was, instead of trying to build de novo a single record, that what was going to happen is that the Department of Defense was going to do a competitive solicitation and acquisition of an updated electronic health record, and the VA was going to modernize their VISTA system.
Well, there is a feeling that there are two systems here, and it seems that maybe the systems are sort of competing to subsume the other. Am I correct?
I don't. It's a good question, but I don't.
It is a good question.
I don't see that that way. One way to look at this is that, again, I think I made this point some time ago, that if we were to ask everybody to hold up their cell phone, we would have a variety of different cell phones, but we could all text each other, call each other, mail each other. We could work documents and then send them to our fellows. Electronic records are like those platforms, and the barrier to sending information and developing that interoperability has to do with the standardized way of handling the data. And so
what we call a common language, right? A dictionary, right?
Yeah, exactly.
Why has it taken us since 2008 to come up with this common thread here?
So this is a national problem. It's not.
Well, it's not a national problem. It's a national tragedy that this has taken so long here. There's no partisan divide here.
And as I mentioned before, we've gone a long way between the Department of Veterans Affairs and Defense last year to map a lot of that data. But one of the things that I think the committee should know is that the majority of our interfaces are with the private sector. So 70% of our dollars are.
Well, actually, the private sector might offer up some, competition to some of the systems that you're employing yourself. But they might have some ideas that might use up the symbiosis of whatever we're talking about here.
And so I think you're right, and that's exactly why we took the tack of looking into the commercial market. The issue is that, as I mentioned before, we're working with the Office of the National Coordinator to push these standards
The Office
out.
of the who?
National Coordinator.
National Coordinator of what?
That's through HHS. They're the ones who set the standards.
So we're going with HHS. Have we always used HHS?
HHS sets the standards relative to this.
So they set the standards for language?
For meaningful use of electronic health records.
And so we didn't tap them before this?
We have been working with them. The issue is that it's really been since 2009 that this has really become a national focus to develop.
It's been a focus of this committee, regardless of who run the committee. And, this is pretty disappointing here, that this has real-life consequences here. And since we're the Appropriations Committee, what's the estimated cost of your new record system? I won't ask what the VA is doing to update theirs, but what's the cost of your new system here?
I think to acquire and fully implement the record, the life cycle cost is going to be around, and this you would have to ask Mr. Kendall, because he is really in charge.
Well, I'm asking you if you have a ballpark figure.
$11 billion.
$11 billion. This is just for you.
Yeah.
And this is the tail, like we'd say, for aircraft or, a ship. It has a tail.
Right. And this is the life cycle.
So maybe we can focus on targets. The target date for the initial operating capability is the first quarter fiscal year 2017, in the full operating capacity, fiscal year 2023, practical, what do you feel is the realistic timetable for this here?
So we have already put out 2 RFPs, and so that process is going along very well. We intend to begin fielding capability last quarter of 2016.
So what happens if the parties you're dealing with here, there's a protest here?
Oh, that's a possibility.
Yeah, there is a possibility.
Yeah.
Now, I just, I think it's enormously frustrating. It makes us angry that we've made these investments here. I don't know who has clean hands, but we have an issue of expectations that we might be able to get across the finish line here. This is way beyond the claims backup, that the VA has. This is pretty damn important. You're giving us a, what sort of level of assurance here that we can meet these deadlines? I mean, and that's a lot of money.
Yeah, it's a lot of money. I feel more confident today than clearly even last year that we will meet those deadlines because the acquisition process is going along, and more importantly, what we've learned from the commercial market about what's out there is encouraging.
Yeah, well, the commercial market's been out there for quite a long time. I know there's a tendency, and I'm respectful, but in reality, sometimes we don't take a look at things that are off the shelf. We try to be inventive on, communication systems. God only knows the amount of money we've invested in communicating. I won't say which service is the worst, but coming up with communications systems. But this is pretty important. Mr. Vysotsky.
Thank you, Mr. Chairman. And I do have a number of questions, and I realize you may have additional ones, Mr. Womack, so I would ask for some brevity. I've got all day, but I think other people do not. I would associate myself, first of all, with the remarks of the chair. More than one instance as a member of Congress, I have referenced World War II. We fought and won a world war in 4 years. We're talking about interoperability of medical records from 2008 to 2017, and I'm appalled. And I just would hope that there going forward is a sense of urgency, and that if something isn't done by Friday, that people don't have the attitude, we'll get to it on Monday. I just can't believe that given the wealth of talent and knowledge we have in the United States of America, that it would take a minimum of 9 years to make medical records interoperable. So I would just associate myself with everything the chairman said and hope that people going forward have a sense of urgency. I'd like to return to the issue of TRICARE, and as I said in my opening statement, I realize just the demographics, if you would, and the math involved both on the civilian and military side are driving a significant budget problem. But I also, in my opening remarks, mentioned equity. And I understand that currently active duty members in TRICARE Prime or TRICARE Prime Remote have no copays as long as they follow Prime rules requiring consultation with a primary care manager to access specialty care or to use the medical treatment facility network. It appears a new plan would treat active duty families somewhat differently if they do not reside near or have access to a medical treatment facility, or if their medical treatment facility does not have a capacity, for example, pediatrics. These families don't have control over their assignments. How will DOD address the issue of equity based on availability and assignment?
So As the plan is rolled out, we recognize again that there will be some individuals who may pay more because of location. That we looked at it, and as I mentioned before, we looked at the numbers as it affected the junior enlisted, and I won't repeat that. On average, their out-of-pocket costs will rise from about 1.4% to 3.3%, an average of about $244 a year. Now, that's an average, and I understand that there may be some folks that need to consume more health care, and if they're in a remote area, it could introduce a larger burden. And the issue is that when you look at, again, the numbers, particularly for junior enlisted, the impact appears to be small because most of them should be near an MTF and could get free care there. But let me give you an example of, so it's pretty clear. So, for example, young enlisted, they utilize less care, but they do use, let's say, OB services. And let's say there's a family that is not near an MTF. The way the system would work is that all preventative care is free. What would happen is that if they needed, they were having a child on the economy, because the payments are bundled, they would be responsible for the one-time admission fee. And so the difference between delivering in an MTF and, let's say, on the economy would be $60 to $80, depending on the geographic area you're in. So, in short, yes, there are some families that might experience elevated costs. I would say, as a final comment, that that's why we have catastrophic caps. So, a family could utilize $1.5 million of care, and their only financial liability would be $1,500 under the proposal.
There have been efforts to increase the use of military treatment facilities. On the theory, you have facilities, you want to maximize their utilization, and decrease care received from private providers. So that was emphasized last year. Is that still an emphasis in the services, and is that consolidation, if you would, of services in medical treatment facilities continuing?
I will let the Surgeon Generals respond, but the answer is yes, that we do need to protect and utilize our military treatment facilities effectively. The financial arrangements under the proposal emphasize lowest cost when they use the military treatment facilities. So there's an incentive to use the military treatment facilities. But I'll let the...
If I could, and I don't want to be rude, but I really do have other questions. I'm assuming from your answer that is still an emphasis.
Absolutely.
Okay. And just a statement, when the Secretary of Defense was in, and I think it's because I majored in accounting, I do hope that the 2017 goal of audibility is reached, and apparently that is still on track, and obviously medical services have a role to play and would encourage you in that. On manning of the medical force, and Mr. Owens had a question, and you mentioned that for some of the specialties in occupations, it's hard to recruit, and there was an emphasis on those in rural areas, which again I think would probably mirror some of the problems the civilian population has. But the Department of Defense had a report that reviewed procedures for accessing non-U.S. citizens with skills vital to national defense, and among them were pharmacists, psychologists, and nurses. There's not enough U.S. citizens being treated that can be encouraged to participate. Do you know? It's not your report, it's a department-wide report, but some of the skill sets they were talking about accessing non-citizens were nursing, pharmacy, and psychology. Is that a problem for you in getting enough citizens?
Again, I'll let the Surgeon Generals respond, but in general, we know that the American medical system has been augmented by foreign medical graduates, and that's been in place for some
Half of the
time.
physicians in my district are foreign-born.
Right.
I understand that.
So that's going to be a persisting issue.
Okay,
And
I
Surgeon
will
General's
defer for the moment, Mr. Chair.
It means he may have more questions. So, Mr. Womack.
Hey, thank you. I've got a couple of items in my binder that I need to get to, and I apologize up front if you've covered these in any depth at all. I know we've talked about mental health access for service members, but particularly to kind of drill down on the separating service member, the person who's got some kind of mental health therapy going on but is separating from the service, and that potential for a disconnect between when they leave and when they pick up treatment once again. What are we doing to ensure that we don't have a break in service? Because I know these service members, that even a short break between treatment or therapy could manifest itself in a very tragic way. So help me understand what we're doing to ensure that we can keep them consistent in their treatment programs. I'll flip a coin if
Okay,
you like.
I'll start out first. So part of what we're doing is first is making sure that we keep our service members going through their treatment to the point where they really are ready to transfer. So we're not transferring them out before their behavioral health therapy is done. We have actually 80% of those that are diagnosed with PTSD actually remain on active duty. So we're talking about that 20%. So those 20% that have a diagnosis that go through the disability system, we focus on care coordination, so a warm handoff to the VA. We also coordinate with the care coordinators that they have nationally, where they oversee the personnel, and so making sure that there is a warm handoff that is there. And then if they are going back into a reserve unit, National Guard or Reserve, then there is that warm handoff from the behavioral health providers to the providers in those units.
In the interest of time, Admiral Nathan, General Travis, is your program similar in that there would not be a transition until the service member is ready?
That's correct, sir. And all of any patient who has a significant issue is generally followed by a case manager, and that case manager also works with VA liaison personnel. The challenge, to be honest, and this is opening the wound the Chairman was talking about, is that often we can get the individual to the VA, but when they get there sometimes, it's not easy for the VA to see what's happened in their care unless they bring their paper record. As Dr. Woodson alluded to, we're working on trying to increase the interoperability of the medical records so that there won't be that lag in clinical understanding, but that's still a challenge for us.
Nothing to add, sir.
Okay. Last month, the Journal of Head Trauma Rehabilitation suggested that a blast, an IED blast, as an example, can affect a soldier even if he doesn't have manifesting symptoms right away. This means that veterans may go quite a while before they have some kind of an issue like a PTSD or depression. What are we doing to reach out to these veterans? And some of these occurred well before we got better at this game. So back in the early part of the new millennium, when the war was first starting. So are we going back and reconnecting and drilling down on those particular members?
I'll take a stab. This is, I think, a fairly good news story. We're not ready to hang the mission accomplished sign up yet, but we now treat concussions and blast injuries in a radically different way than we did at the start of the war. Number one, you are entered into a concussion registry so that we can follow you longitudinally and maintain, just as we do in trauma and cancer. In addition, we now, once you receive a blast injury or any hallmarks of a concussion, the way we treat you at the time, the acute care, is radically different, where you're pulled out of the battle, you're pulled out of the busy system. This is on scene. We have Camp Leatherneck in Afghanistan, where mild to moderate to severe concussion, you're now pulled out and sent to Camp Leatherneck and given reactive tests until you're deemed ready to go back in. this has been so successful, it's been transferred now to sports, to college and high school sports in this country, where people are following that. So I think, to answer your question, sir, the concussion that's occurring today or in the recent years is going to be followed. We'll have a good registry of. We'll be able to document that. The individual will be able to go to the VA and with documentation show the affliction. Prior to the war, we weren't doing that completed job.
Sir, if I could just make one quick comment. 85% of our concussions are actually attributed to garrison, either, injury on car accidents and sports and those types of things. So we learned from the protocol that we had a joint protocol in theater. We have now standardized that across the garrison footprint, and then we're actually putting those individuals into the registry as well.
I'm sure it'd be safe to say that society has benefited from the tragedy of having some of this head trauma happening in our conflicts over the last decade plus. Finally, General Horoho, I mentioned in my first round, Brendan Morocco.
Thank you, sir, for the opportunity to be able to continue to tell his story. He is actually doing well. He's still at Walter Reed right now. He has actually been fitted with 2 prosthetic legs. His brother, who was giving 24/7, support, now doesn't have to do that because he's able to do more himself. Both of his arms, where the transplanted arms, are actually functioning. And probably, I think, the best way to say how this has made an impact is that when the national anthem was being sung, he himself realized in the middle of it that he had his hand on his heart. So to me, if that doesn't strike to why it's important that we preserve our military healthcare capabilities, support research, and keep that warfighter mentality and that spirit, I don't know anything else that does. So thank you, sir.
It's an amazing story, and I am just so very, very thankful for the things that we've been able to do, and credit goes a lot to the leadership espoused by the people sitting at this table today. Mr. Chairman, I truly appreciate their service. Thank you.
I echo your comments, and relative to the issue of research, we get visited by many who support congressionally directed medical research, and they perform, I think, very well, do some innovative things. They do things that are highly risky, but obviously substantiated before they initiate them. The services, the 3 of you as Surgeon Generals are currently responsible, and I mentioned that you have intimate knowledge of these investments. However, that there is a transition, isn't there, to moving some of that responsibility over to the Defense Health Agency. Isn't that true? That was occurred in October of last year. So tell me what the Defense Health Agency does. It's the policymaker for the military health care system, but are they going to substitute their judgment for your individual and collective judgment? What's the working relationship by the creation of this new agency? Or are you the 3 pillars of that agency, or is there somebody else that's?
If you ask us, we're the 3 pillars of the.
We think.
I'm
not going to mention anybody else's name, although I'm aware of other names. But
as a user of the system and as a member of the club, Mr. Chairman, the Defense Health Agency is designed to shoulder some of the services that we provide, ranging from facilities, acquisition, logistics, pharmacy, information management.
I mean, they're involved in the, dare I mention it, electronic medical records too? Or are they separate from that?
They're involved in a very big way in that because because it is an example of something that should be standardized and useful across all the services. We in the services have some very capable but yet redundant and sometimes working at cross purposes services, small s. And so we're fans of trying to standardize those, remove redundancies, create efficiencies, and allow those to be provided to us and guided to us in the same way the Defense Logistics Agency does for logistical support of the three services. So we look at them, or I guess I speak for myself and perhaps the others, I look at it as an organization that is going to support me in my requirements. I have requirements for information management, pharmacy. I have requirements in order to execute my mission. I look to the Defense Health Agency to support me in those requirements.
Well, I have confidence in all three of you, and I'm not sure I need to have you all respond, but if we look to the future, sometimes, at some point in time, after so many years of dedicated service, you may not be on the scene. You may be replaced by equally able men and women. There's a tendency sometimes for people to migrate, agencies to migrate and sort of subsume, your traditional remarkable roles. And I just sort of thought I'd raise the question. You're giving me a level of assurance, at least for this generation of leadership, that that's not going to happen. Anything further, Mr. Visklowski?
Chairman, two lines of questioning, if I could. One, talking about having been at war for nearly 13 years, could you explain any investments you think we need to make today to ensure that the skills and knowledge that have been gained at a great price are, if you would, institutionalized and remain in place? Do you have any current state of manning problems as far as some of your specialties or units? Do you need incentive programs or other intangibles to make sure that some of that medical force personnel maintains that readiness you have today? And then I have one more question, but just how do we keep that energy and expertise that has been purchased at such a high price? How do we maintain that, and do we have a role here as far as any program you're concerned about?
Thank you, sir. If I have the opportunity, and I'm sure my colleagues would like to comment as well. I think it's first vital that we recognize that our military treatment facilities are our readiness platforms, and that it's not the same as, say, civilian health care. We have got to make sure that we're investing in the infrastructure, the capabilities, and the programs that allow our graduate medical education programs to remain as the tip of the readiness spear on how we attract, I think, some of the best and brightest scientists across our nation and healthcare providers. I think that's important. They're the platforms that allow us to maintain that combat capability and knowledge that we had on the battlefield. We've got to be able to take care of our retirees, which are the complex care that allows us to maintain some of those skills sustainment. I think it's important that we continue to invest in technology so that we can use all of the capabilities that are emerging out there for skill sustainment, and then look at those partnerships within the civilian community where we need to.
Okay. Just add a brief comment, sir, if you don't mind. And I would echo everything Patty said, but I would also add, with the budget pressures we've had in the last couple of years, research dollars sometimes the first to go. That and facility sustainment, restoration, modernization. On the other hand, and you'd say, gosh, it may make sense if you're just trying to provide good care. But to really take advantage of all the data that we've been able to collect in this war, thanks to the trauma registry and a lot of our experience, you really do now have to use the research dollars to mine that data, to really get the lessons out of that data, because we've been collecting it. We continue to collect it, but that research has to continue for years to really understand what you've collected and to learn the lessons. We're doing something on Aerovac, saying what's the timing of really getting people back? Can you move them too fast? We're going to learn a lot by mining the data, but I would just tell you that protecting research dollars is just so important. Patty mentioned it. I would echo it.
Is there a specific line item that would be related to that observation as far as research dollars? Because obviously there's a lot of research dollars being spent.
I think we could all probably come up with some line items.
Final issue is with the increased participation of women in the military, and particularly more active combat roles, if you would. Are there any medical developments as far as women who have been deployed in areas of combat that have evolved and changed? And also, are there positions that may have been closed to women in medical services that are being opened now?
I can start, sir. We stood up a Women's Health Task Force over 2 years ago, getting feedback from a sensing session over 200 women from all services in Afghanistan, and we took their feedback. It is now a tri-service, and we've included the VA in this task force. It's led to changes in body armor. It's led to educational changes in the pre-deployment, deployment, and redeployment, changes in behavioral health, how we actually manage and provide a little difference in the way that we support our women versus our men, because the experience is different. It's coming out with actually some tests where for urinary tract infection and other female types of illnesses, so that they don't have to go to a provider. They can actually do self-test and then get the medication in theater, because that was one of the concerns. And then it came out with a urinary device that has already been deployed based on comments that came in the field. So I think we have stood up a women's health service line so that we standardize and really look at the care to women across every aspect of the provision of care. And then lastly, there's work going on with the NATIC labs that is looking at not just females, but what is the standard for men and women to participate in any one of our military occupational specialties, so that we have a common standard that's there.
Thank you, Mr. Chairman.
Thank you. Let me just add another point on the, often the focus is half the people that are homeless on the street every night are veterans, and often the assumption is it's men. But in reality, some of those are women. So I don't mean to put a point on this issue of electronic medical records, but in reality, we need this relationship to come together sooner rather than later. But on behalf of the entire committee, I want to thank you all for your military service and for representing the best of America, those men and women in uniform and many in civilian capacity who served our country as well. We're enormously proud of you. Your job is so important, and we know you do it well. We're proud of you. We stand adjourned.
Mr. Chairman.